Welcome again, and a very happy new year to all of you. Welcome to this part of the second phase of the 6th Global Symposium. I trust you've also been following the other sessions and making the best of the virtual format and the opportunity to participate from your own offices or drawing rooms, wherever you are. My name is Kabir Sheikh, and I'm the policy advisor at the Alliance for Health Policy and Systems Research, which is a partnership based at the World Health Organization. We planned today's session with a number of great speakers, but we would also like it to be very participatory and for us to reflect together and be as creative as possible on what are the meanings as well as the implications for action of this concept that we call learning health systems. After this introduction, we will kick off the session with a presentation, a pace-setting presentation by Professor Sophie Winter, in which will draw on a review of approaches that she's led, approaches to learning health systems. And that will be followed by reflections from our panelists on their own experiences of learning health systems for about 20 minutes. And we'll then go into a question and answer session and round off with concluding remarks by all the panelists. This is a chart that I wanted to start off by showing you, and it shows that there's been a sort of an uptick in the number of publications using this term of learning health systems in the global literature over the past 13 or 14 years. However, curiously, this increase in the global interest in learning health systems is not really matched in low and middle income countries. As you'll see, the lower thread is low and middle income country articles, and it doesn't have the same vigor as the articles from all contexts. And clearly, this shows that learning health systems is increasingly getting traction in the global literature. And there are numerous, and that's well deserved, because there are clearly numerous experiences, examples of learning having contributed to strengthening systems, or more importantly, its absence contributing to failures. And when we consider that, it's actually quite startling why learning has not received more attention in the past when we think about the conceptualization of health systems. Take, for example, the recent experiences of countries responding to COVID-19, where the ability or failure to learn from past experiences with pandemics has often determined the success or the failure of their response. A supportive culture for learning is clearly fundamental to health system strengthening and to the achievement of health goals. But this is not adequately addressed in the conceptualization and in the practical understanding of health systems as they currently stand. Of course, learning health systems is a potentially multifaceted subject, and existing conceptual as well as empirical knowledge on the topic is very fragmented across different bodies of literature on health systems. It should be noted that the Institute of Medicine, which is now the National Academies of Medicine, produced an influential report of this name in 2011, which has been succeeded by several similarly titled but high-income country-based initiatives. And to a large extent, these initiatives have tended to focus on the issue of availability of clinical information to inform decision-making in healthcare settings. So this understanding, this narrow understanding of health systems as conflated with healthcare systems needs to be broadened to reflect the more current understanding of health systems as being complex, adaptive, social, and multifunctional in character. So given all of that, it's quite an urgent agenda to properly understand and to take action on learning health systems, since learning is clearly a key determinant of the strength of health systems and also ultimately of their ability to deliver on health and social justice goals. I should also mention that the Alliance for Health Policy and Systems Research is currently developing its flagship report on learning health systems, which will be published and launched shortly in a separate session. We have many of the advisory members for that report on this panel. So I won't be discussing that here because it's going to be launched separately. But it's clear that this session responds to a larger growing conversation on learning health systems that's increasingly finding resonance across the world. And the flagship report will be an attempt to bring that together and make sense of some of those conversations. So do watch this space, and the flagship report will launch hopefully sometime in the next few months. And now on to the business end of our session. Our panel members represent different actor communities, and in some instances often transcend them. They are policymakers, members of civil society, organizations, researchers, and funders. We'll hear from their experiences and lessons on learning health systems, including successes, failures, their lessons on supportive factors, and on overcoming challenges related to learning health systems. Before we move on to the first speaker, some housekeeping points. So please feel free to put in a question into the live Q&A, which should be at the top on the right-hand side of your screen. And there will be a Q&A at the end of the session, but if you want to insert your questions already, feel free to do so. And please, if you wish to address a particular speaker, mention them so that we can direct the question to that particular speaker. Also, do note that the sessions will be recorded. And if you need support, you can access the support chat function, which is also on the interface page. So we'll start now with the initial presentation from Professor Sophie Winter, who is a professor of international finance, health financing and health systems at the Institute for Global Health and Development, Queen Margaret University, the UK. She specializes in health policy, finance and systems in low and middle income countries, including fragile and conflict affected settings. And she'll be drawing on a recent review of approaches to conceptualizing learning health systems and experiences of learning health systems in low and middle income countries. Over to you, Professor Sophie Winter.
Great, thank you very much. Right, let me find my slides. All right, I hope you can see the slides now. Am I sharing effectively? Can you just confirm?
We can see them, Sophie, but if you wouldn't mind
Brilliant.
Going to full screen, we'll be able to see them better.
Yeah, it's not letting me do that for some reason. How very peculiar. All right, I'm going to just stop and start again to see if that helps. I'm not sure it's one of these. Is that visible now?
We can't see your shared screen yet.
Okay. Is that better?
That's perfect.
Okay, sorry about that. So yeah, thank you very much for offering me this space and time. So I'm going to be just presenting a couple of background papers which were prepared to inform the flagship that Kabir has just been talking about. And as he highlighted, there were two main objectives in this work. One was to look at existing frameworks and approaches for conceptualizing learning health systems. And the other was to review experiences of learning. And the first kind of draws more from various bodies of literature. The second one draws quite heavily on case studies and key informant interviews with people who are working in live learning systems, some of whom are on the panel today. And we're very grateful for their inputs. So two background papers that came out of that. And I will just be picking up some points because I have 12 minutes, so it's going to be a very condensed version. But just to say on the methods, we looked at, it was a sort of exploratory literature review carried out in 2019, and we ended up selecting 109 documents. And as highlighted, these really draw from a wide range of bodies of literature. So there's very few studies that explicitly focus on learning health systems in a low middle income country context, as Kabir was mentioning. We did take some highlights from the kind of higher income country literature, which tends to focus more on the organizational level, but also felt there were some very important framings and insights coming from a range of other areas. And I've just put some of the main ones here. So obviously capacity building and training has a lot of evidence around particularly individual level skill sets and competencies. And that was relevant. On the sort of research system side, there's a big body of evidence around how you support research activities. So that's generating evidence, and also different methodologies, particularly from health policy systems research areas, that were important. There's also a set of knowledge around which with slightly different lenses around evidence translation, evidence-based policy making, implementation science and research, each of which have slightly different framings and focus, but all of them are bringing an important piece of the puzzle that is the learning health system. We drew somewhat from policy transfer and diffusion literature, although less so where it has a kind of push model around, a sort of top-down approach to adoption and adaptation. Quality improvement and assurance, particularly with its sort of reflection, action, learning cycles was important to pull from. And finally, a set of related bodies of knowledge around things such as health sector reform, health system strengthening and resilience. So what are the features of systems that make them strong, that relate to this kind of learning function? And then, as I highlighted, 17 interviews with people working in different settings to draw out more experiential understanding, which to me was the much sort of richer part of the methods. So just to pick out a few elements from the high income country literature, I've put here quite a comprehensive definition from a round table in 2012, which I think is interesting because it brings out the focus on a number of important elements, including informatics. So the kind of data IT side is something that is very significant in the high income country literature, but also recognizing the importance of other areas such as incentives and culture. So there's an emphasis on this continuous process, on a participatory nature, and the idea of a kind of continuous improvement cycle. So the elements which are key out of that are sort of, as we've highlighted, this kind of circular approach, and focus quite a lot at the provider level. So not really conceptualizing the whole system as we would see it in a kind of LMIC context. There is a recognition of the importance of different disciplines, particularly in the kind of action implementation side of the cycle. And I think it's also important to recognize that the kind of driver behind some of this interest, which was partly on efficiency and kind of cost cutting, but is also the search for a more kind of organic, internally driven model of performance improvement, and was a bit of a reaction to some of the top-down kind of target-driven performance management approaches. So when you look at the literature on from low-income country settings, there are very few studies, as we said, that explicitly used that lens when we were doing the search, which is 18 months ago. But one which was relevant and came from the Moroccan setting, from Aknif and his colleagues, produced this relatively simple but I think useful conceptualization, which highlights the importance of the leadership block, so setting the vision and directing the learning process, but also the importance of the environment and the practical processes that support learning. And as you can see in this framework, all of those feed into the kind of three core stages of the learning as they conceptualize it. So basically acquisition of new data and information, the synthesis, interpretation of it in the middle, and then the kind of action element to the right-hand side. And although this is depicted as a sort of linear arrow, it clearly cycles round. So we thought that was a useful starting point. And when we were thinking about a kind of more synthetic framework, bringing together aspects from these different ones, we wanted to highlight the importance of kind of learning at different levels of the system. So we're interested in a way all the way from the international down to the individual level, and recognizing that those processes were going to be different at different levels. And clearly that there are different types of learning that go on, some of them, for example, being more technical, as Kabir was highlighting, of course, clinical aspects and so on, but also some very different skill sets, for example, around political cross-cutting learning. We were very focused on the idea that effective learning is driven from within. So as I said, sort of taking less from the kind of areas of knowledge which are about promotion and sort of promoting uptake from an external perspective. We were interested in how the different building blocks incorporated learning and how they interrelate, but also highlighting the importance of informal systems as much as formal, and the interaction between them, and also between the formal system and communities. And really emphasizing that learning is about effective adaptation to needs and context. So it's not necessary that necessarily around innovations and reforms as normally conceptualized in a sort of structural and large scale way, but can be very much around daily practice and implementation. And that what we're really interested in terms of what we can practically do with this understanding is to understand better the characteristics of learning systems and their enablers. So how can we support their development and sort of a positive deviance model in some way. So picking on examples of where it has worked and trying to understand why and how. So out of that came a slightly unbeautiful kind of overall model, which I don't think is really a final output, but at least is interesting to show in as much as it tries to pick out the different types of processes at each level in which learning happens. But also, so that's the kind of top half, their interaction, as I say, with the more informal aspects on the right-hand side. So really lived experiences, for example, personal networks, social media, etc. And how those relate to the different building blocks, and understanding that within the different functional areas of the health system, you have different processes in which learning occurs, and actually very understudied how that happens and how it can be supported. And all of that fits within the overall sort of action reflection cycle. And out from the literature, we picked out 8 different domains which support, and capacities, if you like, which support these activities. So I'm going to just pick out some of the key lessons that came out in relation to those. So in terms of the overall findings, as we've said, there's a relatively limited explicit literature, but very rich connected bodies of evidence, and definitely a lot of really interesting lived experience which hasn't yet been fully documented, although we are now seeing some studies coming out which pick out some of the lessons from these sites, which is great, but it's still quite an early body of written evidence. We're highlighting the fact that learning is chiefly experiential, and that the key challenge is therefore to create these spaces for communities, staff and managers to reflect on their challenges and find solutions, and that this is really implies a big power shift within the system. And clearly some contexts have been more supportive of that, more willing to kind of cede that power, if you like. And so reflecting on how to sort of encourage and support that is really important. We're saying health systems are knowledge producers, just by the way they work, but that it's not automatic. So obviously it can be blocked, and it can be encouraged. And so this needs to be valued and supported. Some of the case studies highlight effective institutions and processes to support learning health systems. So all of them are facing challenges, but there are some nice, as I say, sort of positive models out there. Some at the local level, obviously, we're still facing some challenges of scaling up. And there are common constraints that come out of the experiences and the literature to learning health systems, and they'll be familiar to all of you, but it's worth just briefly reviewing them. So obviously systems which have very short time horizons, resource constraints, ones in which the whole concept of learning still hasn't really been kind of sold to people who hold the power and hold resources, fragmented accountability, limited research capacity, problems around general inertia, political interest, risk aversion, data shortages, and staff turnover. And those are some of the kind of common elements that come out as blocks. So we're saying overall there's a need for more research, particularly trying to understand the different mechanisms in different settings, and some more empirical study, which is really lacking around how we support those. And particularly, as I highlighted, some of the routine processes, for example, annual planning cycles, routine supervision. There are lots of things which are the kind of workhorses of the health system, but how does learning happen with them, in them, and how is it improved? That's something that hasn't received so much attention, especially since they're not novel. It's seen as a sort of ongoing and routine. So just to pick a few messages from each of the domains, obviously leadership is a really key aspect. We're seeing in some of the settings that everyday governance can create spaces for reflective practice and learning, and I'm sure some of our panelists will be picking up on that. And obviously to support that, there are issues at the individual level around skills that can be improved, but also team level aspects that promote dialogue and collaboration and sharing that overall vision. And highlighting also the need to protect the health system from politicization. And that's something which can be a real impediment to reflection and, effective learning at local level. Of course, organizational culture is also very important. We're highlighting the importance of trust and collaborative relationships, particularly horizontally, but also vertically, and between the different functional areas of the health system and across sectors. And the need to challenge this compliance culture, which is found in many settings. So a sense of inability to sort of deviate from top down and instructions and fear of sanctions related to that. And the importance of the kind of encouraging an ethos of public service, which again in some settings has been more effective than others. In terms of design, organizational design, so there's a need to build this applied research capacity at all levels, and particularly some good examples of sustainable research infrastructure, which we can learn from. Overall, it's really important to align accountability, authority, and capacity, so creating this decision space at the front line and mid-level, ensuring that there's an ability and an incentive to innovate and manage well, which, as we know, can be very restricted in some settings and really dampens any learning capacity or interest. Ensuring inclusion and forum for sharing, and particularly protecting those from dominant interest groups, including commercial interests and donors. Again, I think some of the case studies brought out quite well how that had been managed. It's not easy. And of course, resources and incentives are really important. So learning functions do need to be resourced and particularly embedded within routine processes. And I think we all understand the importance of creating the right incentives for researchers as well, that those who work on sort of policy-linked research can also find that a rewarding career path and not being seen as sort of marginal to core academic work. In terms of external linkages, and this is sometimes external to organisation, not just to system, but the importance of working with partners to demonstrate the value of learning over time. And again, there were some nice examples in the report of institutions which had managed to kind of shift the norms within the political system to generate more demand for evidence-based thinking. And the value of policy networks to build coalitions and share across different constituencies. On the health information and data use side, I think there's still a need for better understanding of what the health information kind of demand is from particularly communities, providers and managers, and ensuring that health information systems are responsive and generate the kind of operationally relevant data, because we all know that many health information systems are weak but also not well used, and so really looking at the kind of information they're collecting and how usable it is at the different levels of the system. And some nice examples starting to come through of kind of digital health strategies. So, e-health, health promotion, health security applications, and how those could be used more effectively in future. but quite an early literature on that in terms of the low middle income country setting. And then final slide, just to highlight in relation to competencies, relationships and mindsets, a bit of a mixed bag there, but obviously absolutely key because all change happens through, the individual. And so recognizing that there's important needs for skills within health systems to engage with the politics of change. So going beyond just the kind of conventional research skills, but also understanding how to sort of challenge paradigms, shift narratives, and build coalitions, for example. And again, we've got people who do that brilliantly, but there's still, a need to broaden those capacities. So how do we do that? And we also need to do it through developing, skilled and respected health system managers at all levels. So some of the case studies really brought out the importance of that kind of valuing and the credibility and status of the sort of management structure, which is not always recognized in all settings. And incorporating some of these learning skills into basic training curricula, which don't necessarily develop them well at present. And finally, sort of developing the governance, which values different kinds of knowledge, which recognizes the importance of experiential knowledge and operational, and creates these safe spaces for reflection and testing of new approaches. And as I said earlier, kind of supporting those horizontal relationships through peer review and support, collaboration and lesson sharing. And again, I think we do have some platforms which have been doing that quite effectively, but they still are sort of early stage kind of pilots in many settings. So that needs to be generalized and learned from. So thank you very much. That's my very quick run through. Back to you, Kabir.
Thank you, Sophie, for your comprehensive overview of the review that you did a few months ago. I think quite sweeping, comprehensive. Also, you captured both the formal and informal ways of learning. Also, this important distinction between learning as innovation and learning as adaptation. I think it's quite challenging to capture the multiple interpretations of such a complex concept, although we all seem to know what we mean when we say learning. It's actually used in many different settings, and your review really helps to pull some of that together. I thought the other really useful thing there was bringing together the idea of learning through information versus learning through deliberation, and also then on the other side, learning through experience and action. So I think that troika of information, deliberation, and action is also something that we are seeking to develop in the flagship report, and I think that's a key distinction, and each of those require their independent input to strengthen. So again, thanks very much for that, and it's a great foundation for taking forward further work on conceptualizing learning health systems, as we've seen, and of course made very difficult by the fact that there is very little specific literature from the low and middle income country context on learning health systems, although as you referred to, there are several peripheral fields or sort of tangential fields which have bearing on the learning health systems literature. So thank you again for that. And with that, we'll now turn to our next roundtable participant, Professor Walid Ammar. Professor Ammar is currently with the St. Joseph University in Lebanon. He's director of the doctorate and research program in the public health program at St. Joseph's University, and former Director General of the Ministry of Public Health of Lebanon, long-standing director. And he will reflect on his long experiences in that role, promoting approaches for learning health systems in a conflict-affected context. So Walid, I'm going to share my screen because it has a description of you, but please go ahead. I understand you don't have any slides.
Okay, thank you. Thank you, Kabir. My intervention aims at explaining in practice how we can create a team learning culture within an organization, how to involve peers in resolving problems and challenging assumptions, and how to promote knowledge exchange among stakeholders to facilitate inter-organizational learning in the health system, by providing examples drawn from my experience in the Ministry of Public Lebanon. My first example is the initiative of transforming the Department of Vital and Health Statistics into a knowledge hub to enhance data production for knowledge to serve evidence-based policymaking, whereby knowledge generation was embedded in the system through building smart information channels between various departments within the ministry and with other stakeholders. Focal points were assigned in each entity for direct information sharing and feedback, hence breaking the silos of vertical data transmission and creating a team learning culture. One of the achievements of this initiative was its impact on the system of identification, reporting, and analysis of causes of death. Death certificates traditionally received from the Ministry of Interior were so delayed and incomplete that they were practically of little interest to inform policymaking. Correcting errors and constantly adjusting by solving administrative problems has been time and resource consuming, leading to short-term unsatisfactory results. An assessment involving stakeholders concluded that the whole system had to be transformed into an electronic and anonymous hospital-based mortality surveillance, where hospitals report directly to the Ministry of Health using ICD-10 coding, while the Ministry of Interior data is used for comparison and supplementation. The system is currently covering more than 80% of the deaths occurring in the country, generating thus more reliable mortality profiles based on timely and actual causes of death, serving the design of targeted policies. So this is an example of the importance of moving from a rigid hierarchical structure to flexible networking with stakeholders in order to promote inter-organizational learning, helping to change mindsets and to break free from pre-established historical institutional arrangements. The second example is on performance contracting to highlight the importance of the ministry's partnership with academia. Within this partnership, academicians and students from several disciplines contribute to the work of many departments and help generating pertinent information for policymaking. This collaboration capitalizes on the wealth of information generated by the daily operation of the health system, where researchers and policymakers work closely to generate knowledge for learning and improving while implementing. The ministry is contracting hospitals to provide care to the uninsured. Hospitals used to boost revenues by increasing unnecessary admissions and inflating investigations and supplies. This created real quality and efficiency concerns. A performance contracting team was set up composed of civil servants and researchers to assess utilization patterns and understand the price structure of the ministry to undertake pricing negotiation based on the reality of costs while rewarding quality and good performance. Contracted hospitals tiers were set on mix of criteria, accreditation score, patient satisfaction, and case mix index extracted from routine data, giving incentives for good practice and discouraging overuse behavior. Performance contracting proved to be an important learning tool for funding agencies to get better value for money, as well as for providers to improve quality and technical efficiency. To conclude, investment in analytical capacity and data-driven negotiation gave policymakers the authority to actively steer purchase of care. The learning experience was not limited. The network of hospitals also went through a cycle of learning while adhering to evidence-based practice. I will stop here and ready to answer any question.
Thank you, Walid. That was very instructive, and I'm sure there'll be many questions on your experience. A very useful example in the post-reconstruction scenario, or the during reconstruction scenario in Lebanon, performance contracting and the importance of data-driven negotiations, and also the valuable collaboration between researchers and policymakers in that context. So I'm sure we'll pick up with questions, but I'd like to move on now to finish off the panelists' interventions, and then we'll move on to the Q&A. So I'm going to share the screen, and next we have with us Walter Flores, who's Senior Advisor and Research Director at the Center for the Study of Equity and Governance in Health Systems in Guatemala. He has over 2 decades of experience working on health systems issues, equity and governance focus, and he'll be reflecting on the significance of lived experiences of users of health services on learning health systems. Welcome, Walter, and over to you.
Yes, great, thank you. Learning health systems is in line with people-centered systems. And because of the many factors and barriers that may affect the planning, financing, and access to services, the specific conditions and reasons that affect user of services are essential for learning. Of course, we can gather user of services experiences through household or exit surveys. But while reaching out to socially excluded populations, traditional surveys may only scratch the surface and not really engaging with the systemic effect of a structural exclusion. For relearning to occur, we need to engage with the lived experiences of those populations. In Guatemala, we support grassroots indigenous organizations in the developing of knowledge and skills to monitor local healthcare services in rural areas. The monitoring emphasizes the lived experience of people while seeking and interacting with health providers and services. By using traditional indigenous practices of listening and storytelling, community health defenders inquire and collect experiences such as, did you feel respected? Did you understand what is your health problem? And the instruction from the provider. Were you asked for any under the table payment? These experiences are synthesized by the community health defenders and presented to local authorities with suggestions on how to improve services. It is very important that this information, this process is owned by the user of services themselves. It's a process that they use to contribute to the learning of the health system. And this process is contributing to a learning health system at local and provincial level. And it has been particularly useful to adapt and provide rapid response to some of the challenges on information, prevention, and testing generated by COVID-19. These structures that we have facilitated together with grassroots organizations has been very useful to local healthcare services to organize around the demands generated by COVID-19. And I'll stop here.
Thank you, Walter. And I'm sure that there'll be strong reflections on that perspective as well. I think the thing that came through strongest for me was community governance and learning as a form of community governance or as a means to community governance. So thank you very much for that reflection, and completely agree with your perspective as well on the people-centered nature of learning. And it's actually people that learn and not the systems. The systems learn through the people learning, and citizens, of course, and communities as very much as part of the health system. So thank you again for that reflection. I see some questions coming through already, but I'll hold them for now. And next we have our next speaker. So I'm going to invite Professor Helen Schneider of the University of the Western Cape, South Africa. Helen is the South African Research Chair in Health Systems Governance and the Director of the UWC Health Services to Systems Research Unit. And Helen will reflect on her experience of researching and advancing better governance for learning health systems at subnational and national levels. So a nice continuity with the previous presentation. Over to you, Helen.
Thanks, Kabir, and greetings, everyone. Nice to be here. So, as Kabir said, he's asked me to reflect a little bit on the nature of learning health systems from a governance point of view. And I think there are really two dimensions of this. The one is to reflect on what governance functions, in fact, promote learning health systems. So what from a governance perspective is required to enable learning health systems, but also what governance contexts, what broader governance contexts actually are required to enable learning. And I think Sophie has reflected actually very eloquently on the kinds of broader systems that enable learning. So coming to the first question, what kinds of governance functions would promote learning health systems? And I would say that the one function that is absolutely critical here is what WHO refers to as the intelligence and oversight function of governance and leadership. And that relates very much to decision-making on what and how information is gathered, how it's triangulated, interpreted, and acted upon, the M&E systems that are instituted. So Professor Amar spoke about mortality, real-time mortality surveillance, performance systems that gather information and enable learning, the technological infrastructures and capabilities, how research systems are engaged, and very critically what Walter reflected on, the systems of citizen feedback. But all of that, while absolutely necessary, I think is not sufficient for generating and catalyzing learning in health systems. And from our observations as embedded researchers in pretty much in one country setting, over a number of years, but also critically in this recent phase of enormous crisis and the need to adapt and learn very, very rapidly, is that system change, adaptability and resilience, whatever you regard as your learning outcome, relies very much on a process of collective sense-making. So in the midst of enormous complexity and crisis, often bordering on chaos, and a huge amount of noise, so an enormous amount of information is generated. From that collective sense-making is the ability to shape collective meaning systems and interpretive schemes in ways that allow people to reach some kind of collective understanding and consensus on the problem or the issue at hand, and most importantly, to be able to define meaningful collective action in response to the problems. So collective sense-making is not a passive process, it's an active process, and will always involve what Kabir referred to as deliberation and action. Bringing together formal and informal knowledge. It relies heavily on situated and context-specific tacit understandings and capacities for storytelling, if you like. And all of that is the critical mechanism, actually, to advance learning in systems. It's the software that accompanies the hardware of information systems, if you like. So governance contexts that enable learning are those that obviously then would encourage participation, allow autonomy and voice, tolerance of failure, that have organizational learning cultures, that systematize opportunities for reflective practice at the coalface, that flatten hierarchies. So it's not so much about what the learning health system plug is that you put into a health system, but really it's about the lens you put on the system as a whole. And I think that's what's so critical about learning health systems. And I think it requires action at micro, meso, and macro levels. It relates very much to broader thinking on health systems and health systems organization. So I will then leave it at that for the time being, and happy to engage in discussion afterwards. Thanks, Kabir. Over to you.
Thank you, Helen. Very short but very incisive, and thank you for keeping it so focused that we could really follow everything about what you said. And I think the key takeaway for me was that you interpret the intelligence and oversight function, and I think that's a key insight that the learning lens brings, and typically that's seen as a centralized or a top-down function, but the way you related it to sense making and the importance of developing collective understanding and consensus is then more about democratizing the process of intelligence and oversight. So that was a really key insight. Thank you so much, and I'm sure there'll be questions. Great, so we're moving along the panel, and I think we're doing okay with time. So we're going to move on to our final panelist, and that is Lola Adedokun. I'm going to share my screen so that you can see her as well. And there she is. Lola is Program Director for Child Wellbeing and Director of the African Health Initiative at the Doris Duke Charitable Foundation. And she works to link implementation research and workforce training to deliver primary healthcare in sub-Saharan Africa. She's going to present her reflections from her experiences in that role and specifically in advancing learning health systems at country and subnational levels in several sub-Saharan African countries. Over to you, Lola.
Hello, everyone. I'm calling in from New York City in a context where having a learning health system is lacking. So I want to just begin with the fact that we are learning as we go as well. So this is not a conversation just to center around the experience of low and middle income countries, but in fact, an opportunity for high income countries with flawed systems to begin to implement and draw on lessons learned from around the globe. So it's a humbling moment, but a moment where conversations like these are incredibly relevant, incredibly important. The Doris Duke Foundation, we're based in the US, but we have been supporting the development and sustainability of learning health systems in sub-Saharan Africa for the last 12 years, supporting work led by national governments, but really truly implemented by the frontline workers at the primary healthcare level in Ghana, Zambia, Rwanda, Mozambique, Tanzania, and Ethiopia for the last several years. I would want to point out, first of all, I really appreciate the comments of our earlier presenters. There are many lessons from their experience that completely resonate from our own. But I want to first make sure that I'm a non-researcher, and I'm more on the side of the consumer of research. As a funder that works both in the United States and in sub-Saharan Africa, it's incredibly important for us to be active, humble consumers of the research that's put out to ensure that we are being held accountable for really supporting and financing evidence-based and in-demand interventions. First, I also want to note also that we have to acknowledge the dynamic between researchers, practitioners, and the general public. And in fact, we have to ensure that researchers, our colleagues, are truly producing research that is meaningful for frontline workers. And that is a different dynamic that has typically been supported over the years. I think first and foremost, if we are truly producing the kind of research that's meaningful, that truly feeds an authentic learning culture, because that's what's in demand. So that's one point I'd like to build on. The second is to Walter's point around the importance of storytelling and listening, and being truly authentic to the culture. I think that's one orientation that is underemphasized and critically important. So I wanted to sort of support that key point. And I'll just share one last point, the fact that we have to think beyond the health system. I think there's nothing like a global pandemic, which would highlight the fact that it's not truly centered just around the health system. In fact, we need to truly engage our colleagues in finance, our colleagues in other sectors, and truly being part of designing questions that are meaningful and also financing the solutions. And then finally, I'll just close with this concept of failure. and building a culture that allows for failure and allows for really acknowledging when things don't work. If we do not support a culture of learning that truly is open to understanding when things don't work and why things didn't work, and the research around that kind of learning, we truly are not building a learning health system. So I hope that from the funder's perspective, this is a useful set of inputs. I know it's certainly not always popular, but in times like these, I think we have to confront real issues, confront the barriers that politics present, but also confront the opportunity for the desire and the demand for learning from what we're doing, from understanding what does and does not work, and for demanding our research colleagues and to begin to do the kind of research that's truly meaningful and translatable for our practitioners and frontline worker colleagues. So with that, I will close, and I'm looking forward to the conversation and Q&A. Thanks all.
Thank you, Lola. And I think that's a great starting point for the conversations, including some of the questions that are coming through. I think your point about acknowledging failure is absolutely crucial. And I come from the context of India, where I find that every 2 years, we sort of find ourselves reinventing the wheel on really crucial health systems issues. And it's this issue of recidivism. We haven't really learned. We keep trying to do the same thing over and over again in the same way without really realizing that there was a particular reason why it didn't work in the first instance. So I think being able to acknowledge error, being able to acknowledge mistakes, and the culture of risk aversion that's so strong in many of these top-down hierarchies, bureaucracies that we see, is a real impediment to learning. So thank you for pointing that out. And maybe that's something that I could ask all the panelists to reflect on as well, in terms of how we learn from failure as a way to kickstart some of the discussions. But first, before that, I do see some questions up. So I'm going to ask all the panelists to put their videos on now, and we will now take questions through for the next 10 minutes, and then we'll finally go into the closing comments from the panelists. So I'm going to turn to the first question, and that's from Karina Kielman, and that's for Sophie. So thanks, Sophie, for the excellent overview. I was curious about the nature of case studies included. What was included, excluded? What counted as a case study of learning? Did you find you were sometimes forced to compare apples and pears due to the unevenness of approaches taken? Sophie, I'm not sure if you need a bit of, if you can see that question or if you grasped it fully. Let me know if you'd like me to repeat it.
No, for some reason I can't see the questions, but I got that one. So thank you very much. Yeah. Maybe I've sort of overstated the nature of the case studies. Case studies in this case, it was a relatively rapid piece of work. And so what I'm really meaning is a kind of rich interviews with key informants. So these were not kind of in-depth, large-scale case studies, although I would make the case for doing more of those in future. I think that would be really interesting to sort of deepen that work. But this was more just picking the brains of people who are sitting in interesting places and trying to make learning systems work and what they have taken from that process. And in that sense, it wasn't really comparing apples and oranges. I think it was more just understanding different contexts and some of the themes that came out. So, for example, and they were non-randomly selected. There were, people who, as I say, have, on the face of it, interesting experiences to offer. We tried to get a range of different settings, so they came from different continents. Some of them draw out themes around, for example, more fragile settings. Others were focused on, for example, in Thailand, the kind of policy Ministry of Health relationship, the institutional framework there, which has been one of the, slightly better documented kind of institutional frameworks for supporting learning. So, experiences from South Africa, drawing from India. So we tried to get a kind of range of settings, as I say, but also each one, I think, brought out a different elements. Some of them were more focused from a funder side or resourcing issues. So it kind of gave a bit of a sense of the landscape, but I don't think we were trying to compare them in any systematic way. So I hope in that respect, it was a quick pass, but sort of it is still insightful.
Thank you, Sophie. And clearly, we're learning how to learn as well through your through research such as your reviews. So it's very interesting to get those insights about the process as well. I see the next question is from Yodi Mahindra Datta. Hi, Yodi. And his question is, as the work was carried out before the pandemic, do you have any additional observations of learning practices of health systems during prolonged emergencies, such as the ongoing COVID-19 pandemic? The question isn't addressed to anybody in particular, so it's open to the floor if anybody would like to respond.
I'll take a first pass. I think this is my response will be not related to the pandemic, but we also have invested in work in Mozambique. And in Mozambique, many of you will know that, 2019, there was a major climate crisis, in fact. The Hurricane Idea and the cyclones truly devastated certain elements of the health system in 2 provinces. And what we've learned by investing in an entity known as the CIAB, the Operations Research Center in Beira, investing in a pipeline of both the researchers who are Mozambican, who really created a center where learning was truly valued, learning that responded to the demands of the health system as part of that element, that arm. In fact, that center became the response center when it came to drawing on data where resources could be allocated in response to that climate crisis. And in fact, it's truly one of those entities that's valued at the national level and at the provincial level as a resource for timely data, high quality data that truly serves as the valued resource to enable health systems to respond to a crisis. That I think for us, that was one of the big wins in our investment, creating and building and valuing an entity that's built for really feeding a learning culture, and that is valued not just in country, but valued by global colleagues who are coming in for an immediate urgent response in a crisis. So I would hope that in other settings, there would be organizations, entities like that are supported by government, who are also valued by the global community as the centers of learning and the centers of quality data when it comes to any kind of crisis. I mean, we all know this is one pandemic of many, unfortunately. And so, investing in those kind of centers is going to be hypercritical, I believe, going forward.
Thank you, Lola.
I can add on that. Yes. Well, in Lebanon, we had a great experience with this pandemic. At the beginning, we have a strong surveillance system that was responsible of case investigation, follow isolated cases, and contact tracing and quarantine. And when we started having a huge number of cases, so the program was overwhelmed. So we had to establish contact with municipalities and civil society organizations. And at that time, the major problem we had was the issue of confidentiality, how we can communicate the names of patients and to follow up. And this issue was legally resolved and getting the consent of patients. And then municipalities and NGOs are part of the system now to respond to the huge need of the big number of cases. So this is a clear example how we can learn and adapt during crisis.
Thank you so much. And that's a couple of great responses to your question, Yodi. And I think really highlighting the importance of institutionalizing learning and dedicating resources towards learning, which I think often gets missed in the search for much harder solutions and more short-term solutions. So I have another question coming from Lucy Gilson, and that's thanks so much, everyone. In thinking about learning systems, how do we balance the formal focus on research and evidence use in these debates with a broader orientation towards engaging citizens or drawing on the tacit knowledge of managers and providers? How can we avoid these debates getting bogged down in the knowledge translation end of the discussion? Who needs to engage differently and doing what differently? So as expected, Lucy has a very insightful comment, really kind of highlighting the crux of the issue. So we're open for responses.
I would like to give some response to it. I think the key issue with it is to make the difference. What is learning, a system that learns versus a system that has feedback mechanisms, for instance. For me, a system that learns, it implies changes in policies, norms, and practices. Very frequently, we have changes in practices, but not changes in policies or norms. Or some other times we have changes in policies, but not in practices. So to me, if we are going to call it a learning system, we want to see a comprehensive integrated change in the policies and the norms in the practice. If this is not occurring, it is not a learning system yet. It's just a system that is using feedback mechanism through research, feedback mechanism through information system, but it is not learning yet. And the greatest challenge for systems to learn, in my view, it is the shifts in power relations that are required. For us, the reason why we are not being able to expand this system that I described nationwide in Guatemala is because the resistance of national level authorities to have to accept that the user of services have a very important inputs that are relevant for the system to learn. That's the most important challenge, that this opposition, that the system, the user of the services do have important things to say, and they are relevant. So I would say that is the difference of research based on health system learning. That is not only about eliciting some evidence, it is about how the shifting of power relations is going to happen, and also how we ensure that the changes occur at different levels, a different governance level, but also not only on the policies, but also on the norms and in the practices as for them.
Yeah, so maybe I could just add to that, Kabir. I think, I mean, I agree entirely with Walter. I think it's very much about institutions and how the regulatory, normative, cultural pillars shape what is possible in systems, and that is very much about how power is distributed. I also wanted to engage a little bit with the prior question about, you know, what enables learning health systems in moments of crisis. And I think one of the things that was incredibly striking about this last period in our part of the world was the explosion in online forms of networking. So how social media, Zoom, you know, all these new modalities just became so rapidly mainstreamed into the functioning actually of systems, and how that enabled actually quite incredible new forms of networking, of opportunities for setting up virtual learning networks in the system when people couldn't meet face to face, and was also crucial to the development of a community-based network called the Community Action Networks in Cape Town Together, which was an incredibly rapidly mobilized network that was centered on neighborhood, first of all, networks that connected with other neighborhoods on the across the city, and which played a huge role in mitigating actually some of the most severe effects of the lockdowns and the restrictive measures actually in the city. And that really was enabled through things like Facebook, WhatsApp groups, of course steered with a very clear political understanding and a clear set of values and approaches to thinking about organizing in systems. So technology on its own doesn't shift power relations, it's how it's used by actors in the system. Thanks.
Thank you, Helen. No, that's extremely insightful. And also just to add to, I think, summarizing in some ways what you and Walter said, it's really about removing the separation between knowledge and praxis. And I think that that separation that Lucy also referred to as the knowledge translation, how do we move beyond the knowledge translation paradigm, that separation is also rooted in a power differential or an understanding that there is a repository of knowledge and there's a repository of action, and that's actually fallacious. And that's what learning health systems really does. It helps us to move beyond looking at that as a dichotomy and more as a continuum. So we are almost at time, unfortunately. So I think we're going to have to move to the last phase of our panel. And I'm going to put all of you on the spot and ask you to answer a couple of questions, if that's all right. But we have had some great questions, but I hope it takes us in the direction that we can start thinking about these questions. Feel free to choose one or both, and I'll go in order of the people I can see on screen. So the questions are, how can we shape a shared understanding of the learning health systems concept? And the second question is, how can we collectively foster and advance this critical health system function? So if it's all right, Walter, I'm going to start with you because you're on my top left on my screen. So over to you.
Yes, I think based on my collaboration in different countries, in different low and middle income countries, is that without calling a learning health system, it's very likely we will find successful examples at local level systems, operational level system of learning system. It is only that we do not have an agreed framework yet, but it is there. And it is there because they have not generated from the top down that now we start implementing learning system, but out of the need of local authorities with user services and organizations to improve the responsiveness and the performance of systems. As in, they may call different ways, but I'm pretty sure there are examples there. So what I think is my suggestion would be, instead of trying to develop the framework and then start everybody to apply the framework, I would suggest try to collect what is already there, to understand how it is already there, and to construct the explanation and the framework based on what is already there, because I think it will be easier for systems to accept experiences that are already out there and they are successful, rather than just trying to initiate a new building block or a new idea called learning health system. I would suggest that we should try to build on what is already there that have different names and then expand from it. I'll stop here.
Thank you, Walter. Lola, you're next.
So I'll just speak transparently from the funder perspective. I'll just take credit. We're one of a few funders who is willing to incentivize a culture of learning. That means that when things don't work, we truly want to hear what didn't work. We also want to give space and time for that thinking. So I think if the funder community could come together and truly agree upon what learning looks like, which we know it doesn't require deep thought. We know that to think and learn requires the space and time to communicate, to share lessons learned, to adopt and adapt practices. If we don't come together and support the time that takes and the time and money that it takes to do that, I don't think we can move forward in building a real robust learning culture. As you say, Walter, there's a lot we already know and a lot that already exists at the community local level, but we have to begin to highlight that, promote that, and support that sort of fire and that willingness to share and learn together as a larger body. So without that kind of investment, I think it'll be very difficult to move forward in promoting this broader agenda around learning health systems.
Thank you, Lola. So Helen, you're next, and I'm hearing that maybe we don't need to move ahead with consolidating the concepts, but really with action. So I wonder if you have another viewpoint or not.
Yeah, I mean, I think it will be difficult to arrive at a single consensus anyway of what the concept is, and it's not, we've all agreed, a single concept that you just add, you know, like a quantum that you can measure. It's much more of a lens. And I think from that point of view, the ability, the role of agencies such as the Alliance, WHO, etc., in promoting that and getting conversations happening at multiple levels on why it's important. I think that learning health systems aren't neutral, they're political. So questions of learning from whom and for what purposes are absolutely critical. And then conversations on what systems enable learning, I think, is quite critical going forward. I think practically we need a lot more research, actually. We need ways of operationalizing quite practically how you see learning at different levels, micro, meso, macro. How do we see learning? How do we operationalize it as a research concept? And then how do we practice it? So it's I think there's a set of challenges there for a research community as well. Thanks.
Thank you so much. Walid, I have you next. Over to you.
Yes, answering your question about fostering learning at system, I would like to highlight the importance of embedding operational research within the functioning mechanisms of various systems components, where knowledge becomes a byproduct of the system's operation. And this would allow to learn from past experience and to track the effects of initiatives in the different initiatives taken in the learning cycles. And also the importance of promoting transversal information sharing across an organization's departments to break silos and create and sustain culture of team learning. This is within the organization. And when it comes to the relation between organizations within the system, I think it's important to transform it. It was mentioned before, to transform the top-down command and control kind of leadership within a hierarchical system into a collaborative governance through networking between organizations to enhance inter-organizational learning. Thank you.
Thank you so much, Walid. And very vital synoptic points there about collaborative governance and leadership. Sophie, I have you last, so you have the final word.
Yeah, thank you. So, yeah, I mean, I think I agree with the points that have just been made. I mean, I do think there is a need to develop a more sort of rich empirical study base here. Because I think we recognise, as we've all been saying, that there's a lot going on that's interesting, that creates the spaces, that challenges some of the political barriers, and which we recognise to be important. But, you know, how did they do it, and how was that shaped by the context, and what can we learn from that for other contexts? So some kind of empirical comparative analysis of that would be really interesting. And I think it's also is important still to sell this function, and to that extent it's understanding the benefits. We know that it's incredibly important, but have we really demonstrated that? You know, have we documented the benefits of learning, or indeed the costs of not learning? In an intuitive sense, I think we have, but perhaps there's a bit more to do on that to make it clear how crucial that is, and it's not just some kind of fuzzy luxury item, but is actually essential and you know, and worth the investment. And on that side, I think it is also interesting to know, if you have a system of citizen engagement of the kind described by Walter, for example, you know, what does it take to sustain that? What are the costs involved? I think it would also be good to share that and understand how you support those over time. So it's the what's working, how and why and where, the kind of realist questions in a way, I think are really important, but also making the case in terms of the broad costs and benefits in a sort of nuanced way, not in some kind of brutal health economic way, but because obviously there's a lot of very intangible, difficult issues in there. But yeah, so I think there's still work to do. It's great that this has risen up the agenda a lot recently. I think the COVID case experience has pushed that, and I do think there's opportunity in crisis. I think some of the case studies even that we did before COVID demonstrated that constraints can create innovation, rapid reaction, new forms, new possibilities, which is a little bit what Helen was describing. And I think we have seen that in a number of settings. So it's not a bad time now, I think, to be really pushing the centrality of this and supporting practically how we do it and putting the research that should go alongside that. Thank you.
Thank you, Sophie. And I don't think I can give a better synopsis actually than all of you have already given. And we're a little bit over time, so thank you to all the audience members as well for their patience. But I'm going to try just summarizing some of the points that came through in about half a minute. I think the key issue here is that we all agree that it's an important element or a facet of health systems and one that's neglected and clearly needs more attention. And I think we also agree that it shouldn't necessarily be looked at as a disparate or a separate building block or an element, but it's a lens and something that needs to flow through health systems. And I think in some ways, the intangible character of it is what has held back its progress as our understanding of strengthening health systems. We also got a lot of support for the idea of thinking about what didn't work and understanding failure better. I think that's something that we all agreed on. And also on actually investing in the institutionalization of learning within health systems, whether through operational research and treating knowledge as a byproduct of health systems functions. That will be a really crucial statement. Or through the support for more local institutions that are involved in not just knowledge production, but also knowledge utilization. Sophie, you made a strong case also for more theorization and more research. And I think in the very practical sense of building the case for a learning health system, which we find it's hard to make because with the very sporadic literature that there is. So I think there's a persuasive case there. And to convince governments and funders that it's worth the investment. And of course, there was a lot of insight on the importance of collaborative governance and leadership. I think that was something that cut across for all the speakers. So clearly, we do need more learning, but at the same time, action on learning can't wait for more research and theorization. We also do need to act. So it's very important to act, to invest in more institutionalization, and actually learning does require investment as well. So I think we need to recognize that learning is not just something that happens, but does require very tangible investments in. So I wish we could give you an ovation because I think that was an absolutely stunning panel for such a short period of time in a virtual format. But thank you very much deeply for your wisdom, your insights in such a short span of time. I understand all the challenges that we're going through right now with communicating effectively, and this was, I think, a great example. So very grateful, and thank you, and have a great day. Bye-bye.
Bye, everyone.